Right. So a very good evening, everyone. Yes. So am I audible properly? Just tell me yes or no. Am I audible properly to all of you? Okay. Right. So in this session, I'll be discussing some of the very important clinical based questions in the general medicine, and this particular clinical based question will be useful for your upcoming NEET PG exam or FMG exam, right? Now, before going on to the discussion of this particular session, before going on to the discussion of this particular session, let me just tell you about the upcoming courses, batch courses on Unacademy. So everyone is aware of this particular plus subscription wherein you will have daily live classes. There are completely structured courses, and you also have live tests and as well as quizzes. And the beauty of Unacademy is that, right, you get subscribed to one particular batch course, you have unlimited access to all the batch courses whichever are going on Unacademy. So for that, you can get discount by using my code, that is MED10. Right, so by using this code MED10, you can get 10% on your 10% discount on your subscription. Now, I think everyone is aware of this iconic subscription also. So Unacademy is providing the live session format, that is live session platform, and as well as the recorded platform of your prep ladder. So that we call it as the iconic subscription. But only thing is, this particular iconic subscription, whatever the prices which are there, they are going to increase. So please try to grab the benefit before the hike has occurred. Okay. Now on Unacademy, we have 2-month calendar for upcoming NEET PG exam, right? Everyone is aware the upcoming NEET PG exam is in the month of September. So in that way, like, Unacademy has designed a very beautiful 2-month calendar course for your NEET PG. And this is the schedule for your 2-month calendar course for your NEET PG, right? Then we also have the similar way 2-month calendar grand test series for your upcoming NEET PG exam. So these are the dates of the grand test series. So you have totally 12 grand tests before your NEET PG exam. So please try to give as many number of grand tests possible, right, which will be very much useful for your upcoming NEET PG exam, right? And we also have ultra fast track high yield revision batch, right? And this particular ultra fast track high yielding revision batch, this will be there only in the month of August and as well as September, and this also will be very much useful for the students who are appearing for the NEET PG exam, right? And for just only 2-month subscription, right, only 2-month subscription, Unacademy has designed a plan, that is a plan of 6750, right? And if you use this particular code MED10, you will get 10% more additional discount on these particular batch courses. Now, for the students who are appearing for the prof exams, right, some of the states, they have the prof exams in the month of December, and some of the states, the prof exams are in the month of February. So for the prof students, we have started with prof courses of general medicine, surgery, and as well as pediatrics, and gradually even gynecology also will be added. So in the prof course, I have started general medicine on July 28th. Still, you can get subscribed to this particular batch course. See, this prof course, the importance is by attending this particular courses, you can comfortably clear your theory exams, right? We are teaching you in prof course in a way how you can get 50% of marks in your prof exams, okay? Right, definitely you can get the distinction also, but our main aim is that everyone should get minimum of 50%, okay? Next, and another important batch course which has started by Unacademy is the FMGE batch course. So those students who are appearing for December FMGE, you can get subscribed to this particular batch course, and even this batch course has been started on 28th of July, right? This batch course will be definitely useful for the students who want to clear the FMGE exam in the month of December, right? And for this, you can use my code, that is MED10, wherein you will get an additional discount on your subscription. So these are the number of batch courses which are going on Unacademy. So you get subscribed to one batch course, you have unlimited access to all the batch courses, right? Now, having said this, let us start. Yes, even Unacademy also has introduced your 4-year subscription course as well. Okay, right. So having said this, let us start with the clinical based questions of the today's topic. Okay, see, it is very easy to crack the clinical based questions and it is little difficult or more difficult for solving the single liner questions, because in the clinical based questions, you know, at least at one point of time the diagnosis will be clicking you, or at one point of time you will be getting a small clue. But for single liner questions it is not the same. Only if you have read that particular line or if you have read that particular topic, then only you will be able to answer that particular question. So by seeing the length of the question, you should not get scared. But these are the type of questions which we are expecting even in the upcoming NEET PG exam as well. Okay, right. Now let us start with the first question. We have a 48-year-old merchant seaman presents with recent weight loss of 2 kg. On further questioning, he complains that for some time he also noticed painful sensation in the legs at the night, reduced sensation in his feet, and some problem with the balance. On examination, he has diminished proprioception at toes. His ankle reflexes are absent. Painless ulceration is seen on the ventral aspect of the big toe. Nerve conduction studies demonstrate reduced motor conduction velocities in the legs with small, poorly formed sensory nerve action potentials. Electromyography shows the evidence of active denervation in the lower limb with positive sharp waves and fibrillations. So what is the most likely diagnosis in this particular scenario? Right, so the most likely diagnosis in this particular clinical scenario is the diabetic neuropathy. Right, it is your diabetic neuropathy. Now, how do you come to a conclusion that it is the diabetic neuropathy? Right, we will take one by one. Right, so all of you, whoever has answered D, that is diabetic neuropathy, right, it is correct. Multifocal motor neuropathy. It is not just only motor neuropathy. In these individuals, you also have the sensory symptoms. You also have sensory symptoms. So what are those sensory symptoms? You see, painful sensations. These are the sensory symptoms. So when there is presence of sensory symptoms, you cannot go with the multifocal motor neuropathy. Okay. Now, you take diabetic neuropathy. It is one of the microvascular complication. So in this question, I will also teach you how to rule out the other options. Right, diabetic neuropathy, it is one of the microvascular complications. Can anyone tell me what are the other examples of your microvascular complications? Yes, can anyone tell me some more examples of your microvascular complications? Yes. Yes, the other microvascular complications apart from diabetic neuropathy, it includes diabetic nephropathy, right, and the other one is diabetic retinopathy. So what this particular patient is having is the diabetic neuropathy. Now we have various forms of diabetic neuropathy. Right, we have the various forms of the diabetic neuropathy. Now can anyone tell me, right, can anyone tell me what is the most common type of diabetic neuropathy? Yes, can anyone tell me what is the most common type of the diabetic neuropathy? Any one of you please? The most common type of the diabetic neuropathy is distal symmetrical distal symmetrical sensory neuropathy. Distal symmetrical sensory neuropathy, you know, this is the most common type of the neuropathy. Right, now what is our patient having? Our patient is having the same, that is distal symmetrical sensory neuropathy. So how is that you will be able to make out that there is reduced sensation within the feet? that is distal part of your limbs, that is reduced sensation within the feet. Now, then followed by that, please tell me, why is this ankle reflex absent in this patient? Why is this ankle reflex absent in this patient? So ankle reflex which is being absent in this patient is suggestive of what? What type of neuropathy does this particular patient have? So the ankle reflex which is being lost, it is the motor manifestation. Right, it is the motor manifestation. So that is the reason why, like, what is the type of neuropathy we consider in this patient? It is not just only sensory neuropathy. This particular patient is having distal symmetrical, right, distal symmetrical sensory motor neuropathy, right, distal symmetrical sensory motor neuropathy. That is the diagnosis of this particular patient, right? What type of neuropathy the individual is suffering with? Distal symmetrical sensory motor neuropathy. Why are you considering motor? Because your ankle reflex is being lost. That is suggestive of right. So I hope, yeah, I'm sorry for the disturbance in between. Right. So this particular patient has both sensory motor neuropathy. Okay. Now, followed by that, let me tell you, in case of diabetic neuropathy, you have multiple types of neuropathy. It is not just only sensory motor neuropathy. There are multiple types of neuropathy in case of the diabetes mellitus. Now, can anyone tell me what is the most common cranial nerve which is affected? There will be also cranial neuropathy. Right, there is also the cranial neuropathy. So please tell me, what is the most common cranial neuropathy in diabetes mellitus? Which cranial nerve is most commonly affected? Right, very good, Swarnalata. So it is the third cranial nerve which is most commonly affected. Now, in these patients with the diabetes mellitus, you know, there is also diabetes mononeuritis multiplex. Can anyone tell me the examples of your mononeuritis multiplex in patients with diabetes mellitus? Yes, any one of you? Mononeuritis multiplex. Anyone? Example of your mononeuritis multiplex in patients with the diabetes mellitus. Yes. So in patient mononeuritis multiplex, you see here, in these individuals, there is also, yeah, there is also involvement of the median nerve, which give rise to your carpal tunnel syndrome. So the examples of your mononeuritis multiplex, there can be either medial nerve neuropathy or there can be ulnar nerve neuropathy, right? So individual nerve is affected but at multiple places. So that will be your mononeuritis multiplex. Now, what is the basic pathophysiology for the development of your diabetic neuropathy? There are three reasons. Number one, vascular insufficiency. That is, can anyone tell me what is the nerve supply? Sorry, what do we call as blood supply to the nerve? Can anyone tell me what do we call blood supply to a nerve? Any one of you? What do we call as the blood supply to the nerve? What is the blood supply to the nerve? Any one of you? So in diabetes mellitus, you know, there is vascular insufficiency of your nerve. But what is that blood supply to the nerve? Anyone? What is that blood supply to the nerve called as? Right? That is your vasa nervosum. So this vasa nervosum, this gets atherosclerosis, right? This gets sclerosed. So thereby what will happen to the blood supply to the nerve? it gets reduced. So vascular insufficiency is one of the cause for your diabetic neuropathy. Next thing is metabolic dysfunction. Please tell me, what are the metabolic byproducts which are formed in diabetes mellitus? Please tell me, what are the metabolic byproducts which are formed in diabetes mellitus, which are responsible for the development of your complications in diabetes mellitus? Any one of you? Yes. What are those metabolic byproducts? Metabolic byproducts, you know, these are glycated end products. Right, these are the glycated end products. Okay, so these glycated end products and as well as the ketones. Okay, so these are metabolic complications what you will see in diabetes mellitus, and that is also responsible for your diabetic neuropathy, right, and possibly autoimmune factors. So these are the reasons why there is development of diabetic neuropathy in patients with the diabetes mellitus, right? Now, then followed by that, if the most common neuropathy just now we have discussed, that is distal, symmetrical, sensory motor neuropathy. Right, distal, symmetrical, sensory motor neuropathy. And you take this autonomic dysfunction. Autonomic dysfunction is also very commonly seen in diabetes mellitus. We call it as diabetic autonomic neuropathy. Can anyone tell me what will be the presentation of the patient with this autonomic dysfunction? What will be the presentation of a patient with autonomic dysfunction? Any one of you? What will be the presentation of a patient with autonomic dysfunction? There are multiple things. One of the very important feature is postural hypotension. Very good, Dr. Kumar. Right, there will be postural hypotension. Right, and yes, very good, Ashwin Brady. There is also presence of resting tachycardia. And there can be your gastroparesis, there can be silent MI. All these will be the features of the autonomic dysfunction. And painless ulcer, yes, it is present in patients with the diabetes mellitus. Why is it painless? Because there is no nerve supply to that particular part of the body. There is no nerve supply to that particular part of the body. So that will be your painless ulcer. Okay, next. Now coming to your alcoholic neuropathy. So please tell me, what are the points which are against your alcoholic neuropathy? Please tell me, what are the points which are against your alcoholic neuropathy? Any one of you, please? Right, let me tell you. See, the points which are against your alcoholic neuropathy is that in case of alcoholic neuropathy, the development of the painless ulcer will never occur. Development of the painless ulcer will never occur in case of the alcoholic neuropathy. Right, it is always the painful sensation. And in case of the alcoholic neuropathy, it is your axonal neuropathy. Right, it is your axonal neuropathy. Okay, that will be your alcoholic neuropathy. Now the other important option is the paraneoplastic neuropathy. So what will be the features of your paraneoplastic neuropathy? See, the features of your paraneoplastic neuropathy is that they are consistent of, right, mainly consistent of the axonal dysfunction. Right, they'll have axonal dysfunction in case of paraneoplastic neuropathy. Right, whereas in CIDP, that is chronic inflammatory demyelinating polyneuropathy, they are consistent with patchy demyelination. Right, patchy demyelination. So yes, now what will be the features of your axonal neuropathy? So in case of axonal neuropathy, please tell me, yes, Kumar Vendani. So in case of axonal neuropathy, please tell me, is it the distal part of your limbs commonly affected or the proximal part of the limbs commonly affected? So it is peripheral neuropathy itself. Peripheral neuropathy itself is your distal part of the limbs. Right, itself is the distal part of the limbs which are commonly affected. In case of the axonal neuropathy, yes, can anyone tell me the differences between the axonal and as well as demyelinating neuropathy? No, no, no. Peripheral neuropathy means it is just only distal neuropathies. Right, let me tell you. See, in case of the demyelinating neuropathy, what will happen to your nerve conduction velocities? Nerve conduction velocities in case of the demyelinating neuropathy, it will be reduced. But whereas in case of axonal neuropathy, the nerve conduction velocities, it remains normal. Right, it remains normal. So in case of the demyelinating neuropathy, the conduction velocity is reduced, but in axonal neuropathy, the conduction velocity will remain same. Right, this is one of the very important difference between your axonal neuropathy and as well as the demyelinating neuropathy. And whether it is axonal or whether it is demyelinating, you will be able to make out only by nerve conduction studies. Right, and it is very difficult to make out on the clinical symptoms. Right, on the clinical symptoms you will not be able to make out. Okay, right. Yes, Kumar Vendani, is that clear for you? You are asking about the differences between axonal and demyelinating. Right. Now we will move on to another. So that was the clinical scenario related to your diabetic neuropathy, which is distal symmetrical sensory neuropathy. Now you take another important question. You are called to see a 35-year-old intravenous drug abuser who in the last few days has developed progressive weakness in arms and as well as legs. On questioning, the patient reports that he had a wound abscesses drained a few days previously and had a stomach bug a few days earlier. Absent bilateral lower limb reflexes are noted on examination. Which of the following diagnoses fit best with this clinical picture? Right, very good, super. So the answer to this particular question is the Guillain-Barré syndrome. Okay, so what are the points? What are the points in favor of your Guillain-Barré syndrome? Yes, very good, Nidish. This particular stomach bug is nothing but your Clostridium jejuni. Sorry, Campylobacter jejuni. I'm sorry, it is your Campylobacter jejuni. That is your stomach bug. It is not botulism, okay? Right? It is your Campylobacter jejuni. Okay. Now, the points in favor of Guillain-Barré syndrome is that, very good. So, absent deep tendon reflexes. These are the earliest feature in patients with the Guillain-Barré syndrome. Okay, good. Who is that? Raj Ravi. Yes. Apart from your absent deep tendon reflexes, what are the other features that you will have in Guillain-Barré syndrome? What are the other features? Very good, Nidish Goel. So, you will have the presence of weakness in the limbs. Right, you will have the presence of the weakness, and this particular weakness, right, this particular weakness, it usually starts in the lower limbs. Right, this particular weakness usually starts in the lower limbs. Then gradually the weakness will progress to the trunk muscles. Right, weakness will gradually progress to trunk muscles. Then followed by that, the weakness will progress to the upper limbs. So this is what is called as the ascending type of paralysis. Ascending type of paralysis. Right, and this particular paralysis will be the flaccid paralysis. Right, this paralysis will be the flaccid paralysis. Okay, right. So that is what you will have in patients with the Guillain-Barré syndrome. That is one important point. Next. Now, apart from your Campylobacter jejuni, what are the other predisposing factors for the development of Guillain-Barré syndrome? What are the other organisms? What are the other organisms which are responsible for the development of this Guillain-Barré syndrome? Any one of you? Right. So the other organisms are mainly the viral infections. Right, mainly the viral infections. Okay. See, actually, does the virus cause Guillain-Barré syndrome? No. The antibodies which are formed against this particular virus, these antibodies will go and affect the myelin sheath of the individual, and that will result in the Guillain-Barré syndrome. that will result in Guillain-Barré syndrome. So what are these name of these antibodies? It is your anti-GM1 antibodies, right? Anti-GM1 antibodies, right? Now what are those viral infections? That is your influenza, parainfluenza, cytomegalovirus and HIV. So these are the, right, these are the viral infections which can predispose the individual to develop this Guillain-Barré syndrome. Now we have a variant of Guillain-Barré syndrome, that is Miller-Fissure syndrome. We have a variant of Guillain-Barré syndrome, that is Miller-Fissure syndrome. Now can anyone tell me what is the antibodies in Miller-Fissures? What are the antibodies in Miller-Fissure syndrome? Any one of you? What are the antibodies in Miller-Fissure syndrome? Right, very good. So that is your see, they will have ophthalmoplegia and as well as ataxia. Good. But I am asking about the antibodies in Miller-Fissure syndrome. Very good. That is your anti-GQ1. Right, that will be your anti-GQ1. So that will be the antibodies that in patients with the Guillain-Barré syndrome. Okay. That is in Miller-Fissure syndrome, a variant of Guillain-Barré, that is Miller-Fissure. Actually in Guillain-Barré it is your anti-GM1 antibodies, right? It is your anti-GM1 antibodies. Okay. Now in patients with the Guillain-Barré syndrome, can anyone tell me what is the most common cranial nerve which is affected in Guillain-Barré? What is the most common cranial nerve which is affected in Guillain-Barré syndrome? Any one of you please? Yes, Kumar Vandani. So why there is ataxia in Miller-Fissure syndrome is there will be cerebellar involvement in patients with the Miller-Fissure syndrome. There will be cerebellar involvement, and that is the reason why there will be ataxia. Right, very good. So it is the involvement of the seventh cranial nerve. But I want to tell you one important point related to your seventh cranial nerve involvement. Now what is that very important point related to your seventh cranial nerve involvement? That is bilateral seventh nerve involvement. Right, that will be bilateral seventh cranial nerve involvement will be there in case of the Guillain-Barré syndrome. Okay, next. Then followed by that, in patients with the Guillain-Barré syndrome, please tell me what is that important CSF finding? Yes, please tell me in patients with the Guillain-Barré syndrome, what is that important CSF analysis finding? So very important CSF analysis finding will be, right, so there will be presence of albuminocytological dissociation. Right, there will be presence of albuminocytological dissociation. That is a very important CSF finding in patients with the Guillain-Barré syndrome. Okay, right, very good, Soumyadi. So yes, Swarnalata, good. Now tell me, what is the differential diagnosis for your albuminocytological dissociation? What will be the differential diagnosis for albuminocytological dissociation? Any one of you please? What is the other condition where you will have this albuminocytological dissociation from Guillain-Barré syndrome? No. Multiple sclerosis. Very good. So we have Saif Shah answering the question correctly. That is Freund syndrome. Right? Freund syndrome, which is nothing but a spinal block. Right? Spinal block. And many of you are telling about multiple sclerosis. Right? About multiple sclerosis. Please tell me what is the important CSF finding in patients with multiple sclerosis? Yes, what is the important CSF analysis finding in multiple sclerosis? Any one of you? In multiple sclerosis, what will be the important CSF analysis finding? Yes, the important CSF analysis finding in patients with the multiple sclerosis is that you will have the presence of oligoclonal bands. This will be the very important CSF finding in multiple sclerosis, right? The presence of oligoclonal bands. Okay, right. Now we have discussed about the CSF finding in GB syndrome, and investigation of choice in GB syndrome is mainly your antibodies, that is anti-GM1 antibodies. Now, in case of Guillain-Barré syndrome, please tell me what will be the drug of choice. What will be the drug of choice in case of Guillain-Barré syndrome? Any one of you? Right. See, the drug of choice is very good, Nitish Goyal. It is intravenous immunoglobulin. Intravenous immunoglobulin, and you have an equal efficacy even with your plasmapheresis as well. And please tell me, is there any role of steroids? Yes, is there any role of steroids, because it's an autoimmune disorder? So please tell me, is there any role of steroids in Guillain-Barré syndrome? Yes, very good, Ranjiv. There is no role of steroids. Now the question is why? Yes, Ranjiv. Why there is no role of steroids? Because it's an autoimmune disorder, right? Antibodies are being formed. Why there is no steroids? Why there is no role of steroids? Anyone? Because it's an autoimmune disorder. Why there is no role of steroids? Right, very good, Ashwin Brady. So in patients with the Guillain-Barré syndrome, antibodies are already formed. Right, antibodies are already formed against your Campylobacter jejuni. Antibodies are already formed against your viruses. Right, there is no new antibody formation. Right, there is no new antibody formation in Guillain-Barré syndrome, and that is the reason why there is no role of your steroids. That is the reason why there is no role of steroids. Right, very good, Ashwin Brady. Now, let me tell you the features of the other options. You take botulism. What will be the very important features of your botulism? Yes, what will be the important features of the botulism? Important clinical features of your botulism. Right. So if you take the important clinical features of your botulism, they mainly have the ophthalmic manifestations. Ophthalmic manifestations: diplopia, blurred vision, photophobia, and pseudobulbar palsy and ataxia. And these individuals with botulism, they have descending paralysis. Right, descending paralysis. And next thing is, you take pseudobulbar palsy. Pseudobulbar palsy, please tell me, is it an upper motor neuron lesion or lower motor neuron lesion? Yes, pseudobulbar palsy, please tell me, is it an upper motor neuron lesion or lower motor neuron lesion? Yes, very good, Kumar Vendani. So your pseudobulbar palsy, it is an upper motor neuron lesion. So that is the reason why, you know, all the reflexes, they get exaggerated in case of pseudobulbar palsy. Right, all the reflexes, they get exaggerated, and even if you see the tongue also, it's a tight or spastic tongue that you will have in patients with the pseudobulbar palsy. Right, whereas bulbar palsy, it's a lower motor neuron site. Bulbar palsy will be your lower motor neuron lesion, but pseudobulbar palsy, it is an upper motor neuron lesion. Okay, and in patients with the botulism, in severe cases, there will be development of cardiorespiratory failure. In severe cases, there is development of your cardiorespiratory failure. Okay. Right. So that is about your botulism. Now you take the tetanus, right? Tetanus. So in patients with tetanus, they will have fever and headache, right? They'll have fever and headache, and apart from this fever, malaise and headache, the other features, like there will be trismus, rhizus sardonicus, opisthotonus, and there will be also development of spasms, right? Trismus, rhizus sardonicus, opisthotonus, and as well as the spasms. See, either you take in patients with botulism, right? What do you give as a treatment? Botulinum antitoxin. And what is that you will give as a part of the treatment for your tetanus? That is your tetanus antitoxin. So either you take botulism or you take tetanus, we just give the antitoxins as a part of the treatment. Okay, right. Now, yeah, yes, who is that? Kumar Vendani. Opisthotonus. Yes, please tell me what is opisthotonus? What is opisthotonus? Any one of you? What will be the posture of the individual in opisthotonus? Yes. So this is what is your opisthotonus. This is what is your opisthotonus. Okay. So there will be arching of the spine. Right, there will be arching of the spine. That is what is your opisthotonus, and it's a characteristic features in patient with the tetanus. Right. Next, what is trismus? What is trismus? Any one of you? And what is rhizus sardonicus? What is trismus? Right, so trismus will be your lockjaw. And what is rhizus sardonicus? What is rhizus sardonicus? Right, so rhizus sardonicus is that where there will be abnormal facial expression whenever the individual smiles. Okay, so yes, so the individual will have the inability to, yes, the individual will have inability to make a proper facial expression. There will be facial grimacing. There will be facial grimacing. So that is what is your tetanus, right? So that was completely about your the botulism and as well as tetanus. In septicemia, what will you have? You will have mainly fever. Right, and even in spinal abscess, what will you have? You will have mainly back pain and as well as fever. But nowhere in the history you have the clinical features suggestive of fever. Right, so your septicemia and as well as spinal abscess, that can be taken out. Right, the answer will be your Guillain-Barré syndrome. The answer will be your Guillain-Barré syndrome. Okay, next. And how is the prognosis in patient with the Guillain-Barré syndrome? How will be the prognosis in patients with the Guillain-Barré syndrome? Is it a good or bad prognosis? Yes, is it a good or bad prognosis in Guillain-Barré syndrome? Let me tell you, in patients with the Guillain-Barré syndrome, they have a very good prognosis. They have very good prognosis. Almost 85 to 90% of them, they recover completely. Right, almost like 85 to 90% of them, they recover completely. Okay, that is what you will see in the Guillain-Barré syndrome. Right, next. Okay, you see another clinical scenario. We have a 72-year-old man attends clinic after recent cerebral infarct. He has been a heavy smoker in the past and had a history of hypertension for which he takes Ramipril. He has made a generally good recovery and is left with some left-sided motor weakness, right? And he is left with some left-sided motor weakness and spasticity affecting his hand as his only residual deficit. Carotid Doppler showed 90% stenosis of right internal carotid artery, right? And he is taking clopidogrel. What would be the most appropriate treatment for this man? Yes. Excellent. So who is that? Nidish Goel. Yes. So this particular patient has to be referred for carotid end arterectomy. This particular patient has to be referred for carotid end arterectomy. Now, why is that this particular patient has to be referred for carotid end arterectomy? What is the indication? Right. What is the indication for carotid end arterectomy? What is the indication for carotid end arterectomy? Yes. Very good, Nidish Goel. So, if the carotid artery, if it is stenosed more than 70%, if the carotid artery, if it is stenosed more than 70%, that is an indication for carotid end arterectomy. Right, that is an indication for carotid end arterectomy. Okay, right. Now our patient is having a carotid artery stenosis of almost like 90%, and that is the reason why this particular patient has to definitely undergo carotid end arterectomy. So what is the cause for stenosis in this patient now? The cause for the stenosis, sorry, what is the cause for the cerebral infarct in this particular patient now? That is because of the that is because of carotid artery stenosis. Okay. Now please tell me, what are the risk factors in this patient for the development of carotid artery stenosis? What are the risk factors carotid artery stenosis in this patient? Yes, quickly. Very good, Nidish Goel. Number one, right? Number one, the individual is a smoker. That itself is a very important risk factor. Next. The other thing is hypertension. Very good, Raj Ravi. And other thing is age of the individual. Other thing is the age of the individual. These three are the important risk factors for an individual to develop the carotid artery stenosis. For the individual to develop the carotid artery stenosis. Okay, next. So, apart from that, you take the cerebrovascular accidents. So, let me know, is it ischemic stroke more common or hemorrhagic stroke more common? Yes, is it ischemic stroke more common or hemorrhagic stroke more common? Any one of you? Which is more common? Very good, MD medicine. So it is ischemic stroke more common, right? And for the development of ischemia, tell me now, thrombosis is more common, right? Is thrombosis more common cause, or is the embolism most common cause for the development of ischemic stroke? Right? Ischemic stroke is most common then compared to that of hemorrhagic stroke. That is done. Now tell me, what is the cause for your ischemia? Is it thrombosis or is it embolism? Right, the most common cause for your ischemic stroke right, the most common cause for the ischemic stroke will be thrombosis. Right, thrombosis will be the most common cause for your ischemic stroke. Okay. Now, after having discussed about the ischemic stroke in this individual, now for suppose if the same patient, right, for suppose if the same patient has presented to you within 4.5 hours, if the same patient has presented to you within 4.5 hours, will you thrombolize this patient or not? The same patient has presented to you within 4.5 hours. Will you thrombolize the patient or not? Or do you want any more history? you want to thrombolize. Okay, so a known case of hypertension, 72-year-old man, without knowing the blood pressure, you want to thrombolize the patient. See, immediately you should ask me, yes, more history is required. More history is required. What is that? Immediately you should ask me, sir, what is the blood pressure of the patient? Because you are telling that he is hypertensive. I want to know what is the blood pressure of the patient. Without that, I cannot thrombolize the patient. Right? Definitely, I require the more examination and as well as more history as well. Okay. For example, I will tell that the blood pressure of the patient is 185 by 110 millimeters of mercury. Now you tell me, will you thrombolize this patient? Now tell me, will you thrombolize this patient when the blood pressure is like 185 by 110? Right. The answer is no. The answer is no. So when I have asked you a question, can I thrombolize this patient if the patient is coming to you with less than 4.5 hours? Don't immediately jump onto the point of thrombolysis because he has presented to you in a window period. Right? You should see the contraindications for thrombolysis also. You should also see the contraindications for thrombolysis. If there is any contraindication for thrombolysis, you should not do. Right, so you should be very much careful before thrombolizing the patient. You should ask the entire history before thrombolizing, and then only if there is no contraindications you can go ahead with your thrombolysis. Okay, and what is the very important thrombolytic agent? What is the very important thrombolytic agent? Yes. What is the very important thrombolytic agent in individuals with an ischemic stroke? It is your recombinant tissue plasminogen activator. It is your recombinant tissue plasminogen activator. Okay. Now, what should be the dosage of your recombinant tissue plasminogen activator? Right. So, it is 0.9 milligrams per kg body weight, and it should not exceed more than 90 milligrams. Right, it should not exceed more than 90 milligrams. Okay, maximum it should be 0.9 milligrams per kg body weight, and it should not exceed more than 90 milligrams. Okay, now even this also 10% you should give bolus. 10% you should give bolus, and the remaining 90% should be given over 1 hour. Right, the remaining 90% should be given over 1 hour. Okay, so this is about your thrombolysis in a patient with the ischemic stroke. Now, in this patient, and as an option given to you, you have to go ahead with the carotid endarterectomy because the carotid Doppler is showing almost 90% stenosis in the internal carotid artery. Now, among your anterior cerebral artery, middle cerebral artery, and posterior cerebral artery, involvement will cause ischemic stroke. Right, ischemic stroke. Tell me, which is the most common vessel which is affected for the development of CVA? Which is the most common vessel which is affected in the development of CVA? It is middle cerebral artery. Right, it is middle cerebral artery. Middle cerebral artery is the most common vessel which is affected in the development of your cerebrovascular accident. Okay, right, it is not your posterior cerebral artery. It is your MCA. Now the question is why? Why middle cerebral artery is most commonly affected? Why middle cerebral artery is most commonly affected? Anyone? Yes. Can anyone tell me why middle cerebral artery is most commonly affected in the development of cerebrovascular accidents, then compared to that of your ACA and as well as PCA? Yes, who will be the first person to answer? Right. So the answer is that MCA it is an end artery, right? It is an end artery. You don't have the anastomosis for your MCA. That is one point. And second thing is MCA, which is the branch of your internal carotid artery, it is exactly straight. You don't have any bend or you don't have any arching. So if there is any embolus which is coming from the heart, it will directly go to your middle cerebral artery. Because middle cerebral artery is not like the arching, middle cerebral artery is not like having any bend. So that is the reason why the middle cerebral artery is most commonly affected. Then compared to that of your anterior cerebral artery and as well as the posterior cerebral artery. Now, after the initial treatment, either by thrombolysis or by your end arterectomy, the next important thing is you need to give antiplatelets, right? So tell me, is there any role of anticoagulants in ischemic stroke? Yes. Is there any role of anticoagulants in ischemic stroke? Yes, please tell me a quick answer. Is there any role of anticoagulants in ischemic stroke? Very good, Antarshri. There is no role of anticoagulants. There is no role of anticoagulants. But you can give low molecular weight heparin. Right? You can give low molecular weight heparin. Why? Low molecular weight heparin or unfractionated heparin, what you are giving is not for your ischemic stroke. These patients with stroke, ischemic stroke, they are bedridden. So there is a chance of development of deep vein thrombosis. Right? There is a chance of development of deep vein thrombosis. So in order to prevent the development of deep vein thrombosis, we give this low molecular weight heparin, but not for the ischemic stroke. Okay, so that is about your warfarin. And the antiplatelet what we give in ischemic stroke, it is aspirin. So aspirin, it is preferred over clopidogrel because the studies have shown that the improvement is more with the aspirin rather than your clopidogrel. So adding your dipyridamole will be of not much use. Okay, and switch to your aspirin and dipyridamole in this clinical scenario is not correct because the carotid artery, carotid Doppler, it is showing 90% stenosis. So you have to do the carotid end arterectomy. You have to do carotid end arterectomy, right? So that will be the treatment in patients with your cerebral infarct. That will be the treatment in patients with your cerebral infarct. Now, I just want to ask you some quick questions related to the presentation of the patient. See, he has made a good recovery and is left with some left-sided motor weakness and spasticity affecting his hand as his only residual deficit. Right? Now, you take this spasticity. Why there is development of spasticity in this individual? And what is the site of the infarct? Please tell me this. Why there is spasticity and what is the site of infarct in this patient? Why there is spasticity? That is because of involvement of your upper motor neuron, that is corticospinal tract. It is the involvement of upper motor neuron, that is the corticospinal tract. That is the reason why there is spasticity. Now, you consider this is your cerebral hemisphere. Consider this is your cerebral hemisphere. Okay, I'll give you two sides, side A and side B in the cerebral hemisphere. Now, in this patient, tell me which particular part of cerebral hemisphere is affected. Is it your side A affected or side B affected in this patient? Is your side A affected or side B affected in this patient? Yes? Yeah, okay. It is your middle cerebral. No. It is not your side B. It is not your side B. See, if you take the topographic presentation of the where is your weakness, motor weakness and spasticity affecting the hand, right? Motor weakness and spasticity affecting the hand. How will be your topographic presentation of the human the cerebral hemisphere? Right? This will be the topographic presentation. Right? Your B is for legs. A is the upper limbs. A is your upper limbs. Now, where is the weakness? There is some left-sided motor weakness and spasticity affecting the hand. So, which part of the cerebral hemisphere do you think that might have been affected? It is your part A. That is superolateral side of your cerebral hemisphere. It is not the medial aspect of the hemisphere. Medial aspect of your cerebral hemisphere, it is concerned with the motor activity of your legs, not with the motor activity of your upper limbs. So it is side A affected, not side B affected. Right? I hope everyone is clear with this. Yes, all of you? Okay. So this is the clinical scenario related to your cerebrovascular accident. This is the clinical scenario related to your cerebrovascular accident. So with this, I'll just wind up this particular session, right? So I just tried to take up one particular clinical question or 2 or 3 clinical questions, and I tried to eliminate the other options, substantiating why the answer is C or substantiating why the answer is B. And always you have to remember one important rule in the clinical based questions. Don't read the question from first. First read the last line. First read the last line in the clinical based question. Then you will know what exactly is the question. Your first important thing is your only history. Right? Sometimes there will be unnecessary history will be there in the question. That will be increasing the length of the question, and that becomes very difficult to us to concentrate also to read the entire question. So always read the last line, then you start reading from the top of the question. That makes sense in answering the questions as well, right? So I'll be coming up with few more sessions related to your clinical based questions. So tomorrow also, right, we are doing an integrated session. So we are integrating obstetrics and as well as the general medicine. So tomorrow at 7:30 p.m. right, tomorrow at 7:30 p.m. I will be doing an integrated session integrating general medicine and obstetrics with Dr. Ramya at 7:30 p.m. This will be on Unacademy platform. This will be on Unacademy platform. This will be a special class. Right, this will be a special class. Okay, right. So with this, I will wind up this particular session, and a very small information to all of you, right, about the prof exams. So many students, they feel a lot of difficulty in clearing the prof exams. So in order to see that the prof exams should not be difficult for you people, Unacademy has come up with this particular batch course, that is prof course. Right, in which we have started with the general medicine first. So this course has been started on July 28th, and those students who are appearing for your prof exams, please get subscribed to this course. This will be definitely useful to clear your prof exams in a single attempt, right? And you can use my code, that is MED10, for additional discount on your subscriptions, right? With this, I'll wind up this session. See you again in the upcoming sessions. Thank you very much.